Hello and welcome back to the Fall 2023 IJEP program. In this talk, we will address the special considerations when prescribing for the older adult. The objectives of this talk are: be able to describe key issues in geriatric pharmacotherapy, effects of age on pharmacokinetics and pharmacodynamics, risk factors for adverse drug events for older patients and ways to mitigate them, and the principles of prescribing for older adults. This graph illustrates the present and growing use of prescription medications by the older population in the United States. Adults 65 years and older are prescribed the highest proportion of medications in relation to their percentage of the U.S. population. Unless you are practicing in an exclusive pediatric practice, you will be prescribing medications for older adults. For optimal therapy and patient safety, it is important to know and understand the special considerations of prescribing for this population. First, we will discuss the effects of aging on pharmacokinetics: absorption, distribution, metabolism, and elimination. The extent of drug absorption is not changed, but the rate of absorption may be slower. Drug-drug interactions and comorbid illnesses can have an effect. For example, proton pump inhibitors are very commonly used medications, and because of alterations in gastric pH, can affect the rate of absorption of pH-dependent controlled-release medications. Thin skin and reduced blood flow to the dermal layer can decrease absorption of topical medications. Normal body aging changes can alter volume of distribution. As the body ages, lean body mass and total body water decrease and can decrease volume of distribution of drugs that bind to muscle and hydrophilic drugs. Total body fat in relation to body mass tends to increase, causing an increase in volume of distribution of lipophilic drugs. Poor nutrition leading to lower serum protein can lead to a higher percentage of a drug that is unbound and active. As we know, the liver is the primary site of drug metabolism. Age-related changes include a reduction in hepatic size and blood flow to the liver. This may lead to a reduction in metabolic clearance by the liver. Drugs that undergo an extensive first-pass effect tend to have a higher serum concentration or increased bioavailability. Consequently, less drug is extracted by the liver. Lower dosages may be therapeutic. Most drugs are renally cleared. Changes in renal function due to normal aging or diseases can reduce elimination and an increased risk of toxicity. With normal aging, decreases in kidney size, renal blood flow, number of functioning neurons, and renal tubular secretion result in decreased renal function. Renal function must be considered whenever you are prescribing a medication or doing a medication review for an older adult. Creatinine is a product of muscle and protein metabolism and released by the body at a constant rate. It is used as an indirect measure of renal function, but is not reliable. Use a formula to estimate creatinine clearance and estimated glomerular filtration rate. The lab used by your organization will use a specific formula, usually one shown on this slide. You should make sure you have one available to you on your phone via a medical calculation app. Probably the two most common formulas are the Cockcroft-Gault and the MDRD equations. There are limitations to both regarding older adults. In patients without a significant age-related decline in renal function, the Cockcroft-Gault equation underestimates creatinine clearance. In patients with muscle mass reduced beyond normal aging, think about a thin, frail, older adult, the Cockcroft-Gault equation overestimates creatinine clearance. The modification of diet in renal disease, MDRD, is not validated in adults 85 years or older, or in racial or ethnic groups other than white and black Americans. As noted before, normal aging leads to reduced lean body mass, which yields lower creatinine production when paired with a reduced glomerular filtration rate, GFR. Serum creatinine stays in normal range, masking serious changes in creatinine clearance. So even if an older adult serum creatinine is in the normal range, renal function may be reduced. If I have any questions about a patient's renal function, I will perform a calculation with one of the previously mentioned equations before prescribing. Older adults may have altered pharmacodynamics due to changes in receptor affinity or numbers, post-receptor alterations, and/or an impairment of homeostatic mechanisms. Pharmacodynamics can be less predictable and often can lead to an altered drug response at usual and lower concentrations. This is why it is important to always check in with your patient about effectiveness and adverse side effects after prescribing medications or at any medication review. As discussed in the last talk, any medication you prescribe should always align with what matters most to your patient and have minimal risk to cause changes to mobility, increase fall risk, or impact mentation. Successful prescribing relies on you as the provider to use the correct drug at the correct dosage, targeting the correct condition, and choosing one that is appropriate for the patient. Failure in any one of these can result in adverse drug events, which are an injury resulting from the use of a drug, or an adverse drug reaction, which is a type of adverse drug event, referring to harm directly caused by a drug at usual doses. When you are reviewing a patient's medication list, always keep in mind these risk factors that can lead to adverse drug events. 6 or more concurrent chronic conditions, 12 or more doses of a drug per day, 9 or more medications, prior adverse drug event, a low body weight or low BMI, age 85 or older, an estimated creatinine clearance of less than 50, or multiple providers prescribing. Also be aware that adverse drug effects can result in a prescribing cascade where another drug is prescribed to counteract the side effects of an already prescribed drug. For example, a patient may be prescribed amlodipine for hypertension. The patient develops lower extremity edema, which is a common side effect. Furosemide, a diuretic, is then prescribed to reduce the edema. This practice can lead to polypharmacy, which is taking 5 or more medications. Polypharmacy in the older adult population leads to an increased risk of falls, changes in mentation, and increased risk of non-adherence. Mentioned earlier in this talk, drugs may interact with each other and cause adverse drug events or unexpected outcomes. As for adverse drug events, risk for these interactions increases with the number of drugs prescribed and multiple providers prescribing medications. These interactions can affect absorption, exaggerate or dampen effects of drugs, or affect metabolism. For example, renal function may be reduced with diuretics, affecting the clearance of other medications. Non-adherence to medications is a common problem in older adults and can occur for many reasons. Any medication that is not in line with what matters or potentially impacts mentation or functional status is at risk for not being taken. Other risk factors are listed on this slide. With every medication review, identify barriers to non-adherence, making sure that what matters most is always kept foremost. Inquire about difficulties taking medications and adverse effects. Review medications and how a patient is taking them. Think about a multifaceted approach using approaches listed here, if feasible, to support adherence to medications. Before prescribing a new medication and at each transition of care, a medication review or medication reconciliation should occur to ensure that appropriate medications and doses are continued and unnecessary ones discontinued. If appropriate, make sure you educate your patient about potential side effects and drug-drug interactions, and always make sure that it aligns with what matters most. When prescribing for older adults, the adage, start low and go slow, prevails. Review prescribing guidelines in a resource such as Hippocrates, which will include recommendations for beginning doses for older adults and give dosing regimens for renal or hepatic impairment. Always try to avoid prescribing or stopping 2 drugs at the same time, so that if your patient does experience a side effect, you can more easily determine what may have caused it. Review and scrutinize any medication that is prescribed by another provider. Because of our fragmented healthcare system, different providers may not have accurate medication lists or be unaware of particular risks for older adults when prescribing. Deprescribing is just as important a process as starting a new medication and should be considered at every care transition and annual visit. Always remember to monitor for withdrawal, disease worsening, or adverse effects, and communicate your plan to the patient, family members, and other providers. There are a number of websites that provide useful guidance for deprescribing, including appropriate circumstances for stopping a medication. As we have discussed before, as a person ages and the body and life circumstances change, medications may no longer be appropriate if they are not positively impacting the 4 M's of age-friendly healthcare. One of the most useful tools to guide you when you are prescribing for older adults is the Beers criteria, which you will review prior to coming to class. Published by the American Geriatric Society, it is reviewed and revised every 4 years. These are evidence-based guidelines that recommend drugs to avoid in patients with specific diseases or syndromes, and drugs to use with caution. Its purpose is to identify potentially inappropriate medications that should be avoided in many older adults, to reduce the adverse drug events and drug-related problems, and to improve medication selection and medication use in older adults. The Beers list is designed for use in any clinical setting and is also used as an education, quality, and research tool. There are 7 key principles to guide optimal use of the Beers criteria, but the most important take-home message is this: use clinical common sense. The Beers criteria are intended to support, not contradict, common sense and good clinical care. Let's review the 7 principles. Principle number 1 states that medications listed are potentially inappropriate, not definitely inappropriate. The Beers criteria comprise meds which have unfavorable balance of benefits and harms for many older adults, particularly in light of available alternatives. But there are some older adults in which use of Beers criteria meds can be appropriate. Beers criteria medications should not be considered definitely inappropriate for all older adults. Principle number 2, read the rationale and recommendations. Medication appropriateness is not black or white. Many medications are considered potentially inappropriate only in certain circumstances. Understanding the true meaning and purpose of each criterion is critical for proper interpretation. Principle number 3, understand why medications are included in the criteria and adjust your approach accordingly. It is not enough to know that a medication is included in the criteria. Clinicians should know why it is there. This information is provided in the rationale statement of each criterion. This allows you to individualize decision-making for individuals based on their anticipated risk and for what matters most. Principle number 4, optimal application of the Beers criteria involves offering safer, non-pharmacologic and pharmacologic therapies. Often the best alternatives involve non-pharmacologic strategies, including patient counseling and lifestyle changes. Principle number 5, the Beers criteria should be a starting point for a comprehensive process of identifying and improving medication appropriateness and safety. The criteria capture only a small percentage of medication-related problems in older adults. The criteria work best when used as a starting point to review and discuss a patient's entire medication regimen. This involves addressing a range of issues, including but not limited to medication appropriateness, adherence, adverse events, and what matters most. Principle number 6. Access to medications included in the Beers criteria should not be excessively restricted by prior authorization and/or health plan coverage policies. As noted before, there are times when these medications are appropriate. Difficulty accessing these medications may be harmful. Principle number 7. The Beers criteria are not equally applicable to all countries. The criteria were created principally based on medications available in the United States. If you are practicing in another country, it is reasonable to use broad-based categories of the criteria to identify potentially inappropriate medications. In summary, appropriate prescribing means choosing the correct dosage of the correct drug for the condition and individual patient. Age alters pharmacokinetics, including drug absorption, distribution, metabolism, and elimination. Adverse drug events are common but can be minimized with strict attention to risk factors, drug-drug interactions, and drug-disease interactions. Use the tools described in this lecture to help you optimally prescribe for the older adult.